Good afternoon, dear colleagues. My name is Artem Kuzovlev. I am intensivist from Moscow, Russia, and I am the head of Nigovsky Research Institute of General Reanimatology. And the topic of my current presentation is tailoring education on different groups. This year, I'm having an honor of being the member of the team preparing new ESC Guidelines 2020. And this presentation reflects my work in this team. So what about tailoring education on different groups? Over the years, cardiopulmonary resuscitation was taught to healthcare professionals and some lay persons with duty to respond. We all know that the specific educational needs of this group lie on a continuum, depending on who needs to be taught which CPR competence, from simple to complex, from basic to advanced levels. And all of these data triggers the intervals, frequency, duration, training and retraining, along the need teaching equipment for the level of training and assessment. Basic life support, cardiopulmonary resuscitation is the basics, and every concerned citizen in Europe must learn to provide basic skills to save life. And lay people, and also people with duty to respond in emergency, they have to be taught resuscitation competencies depending on the level of rescue and according to the European Resuscitation Council guidelines. We know, and there is evidence, that training and retraining is quite important, and that resuscitation competencies are best maintained if training and retraining is distributed over time. And frequent retrainings are suggested between 2 and 12 months. Healthcare professionals should be trained on advanced life support training, better on accredited adult life support courses, and they also have to use cognitive aids and feedback devices. Moreover, specific team and leadership training, data-driven performance-focused debriefing are key elements of healthcare professionals' resuscitation training. So what is the primary goal of training bystanders and first responders with duty to respond? 3 goals: to increase immediate lay responder CPR rates, to perform effective BLS and AED use, and to timely activate the emergency response system during out-of-hospital cardiac arrest. So this is chain of survival, definitely. And the key points in resuscitation education for bystanders and first responders with duty to respond are: enhanced willingness to perform CPR, train the chain of survival, train using various feedback devices, at least the metronome, use spaced education, and use frequent retraining. So what is the evidence for that? We know we have some evidence, and the latest is from 2020 co-structure, that enhancing willingness to perform cardiopulmonary resuscitation as a part of the CPR teaching in this population may have a direct impact on survival rates for out-of-hospital cardiac arrest. Chain of survival is the key for basic life support and advanced life support, and definitely all bystanders and first responders with duty to respond must be trained on how to recognize cardiac arrest, alert emergency services, and how to run BLS, especially quality chest compressions, and how to use AED. Use of feedback devices during CPR training that provide directive feedback on rate, depth, chest release and hand position is suggested, with weak recommendation, low certainty evidence. If you don't have directive feedback devices, you can at least use tonal guidelines like music or metronomes, which might be used to improve compression rate only. What about the spaced learning? We have data from 2020 evidence review that spaced learning, so learning distributed over time with several retrainings and reminders, it seems to be more effective than mass learning. It's a weak recommendation with very low certainty of evidence. And the recommendation for an increased use of space CPR education is valid for both non-healthcare professionals and healthcare professionals. So, what about the cognitive aids? We have, unfortunately, insufficient data for or against the use of cognitive aids for lay provider training. And we have data that frequent retrainings, short courses and retrainings are very important for the lay people. But we have insufficient evidence on the optimum interval or method of BLS retraining for lay people. We know that skills decay within 3 to 12 months after the initial CPR education. But evidence suggests that more frequent retraining improves skills, responder confidence, and willingness to perform cardiopulmonary resuscitation. So what about the healthcare providers? The key points in resuscitation education for them. Every healthcare provider must be taught high-quality CPR. That's of no doubt. From BLS to ALS level, both pediatric and adult, maybe special circumstances, depending on the workplace. Advanced life support course, an accredited advanced life support course, is a golden standard for healthcare providers' CPR training. And this accredited course must include team and leadership training. Cognitive aids should be used in healthcare providers' resuscitation educators, along as various debriefing techniques. So, high-quality resuscitation education is mandatory for healthcare providers at all levels, from basic to advanced life support, for children and adults. Depending on the workplace, requirements for the CPR competences may vary. You may train special circumstances. And definitely BLS education for healthcare providers is in principle not different from resuscitation teaching in non-healthcare providers, but in special circumstances, specific competencies need to be added to the standard BLS teaching. Neonates, COVID-19, special alterations in BLS and ALS algorithm for COVID-19 patients. We all know the excellent DRC guidelines for that. Special in-hospital environments, operation rooms, etc., etc. As I have told already, accredited advanced life support education for healthcare providers, that's the golden standard. And we have data for that with weak recommendation, a very low certainty of evidence. We may use both low and high fidelity mannequins. Low fidelity mannequins are more suggested and acceptable for the majority of ALS trainings in an educational setting, but in the center where we have the valid infrastructure, trained personnel, and enough resources to maintain the program, we can use high fidelity mannequins. Specific team and leadership training is the cornerstone for the ALS CPR education for healthcare providers. In contrast to evidence found for bystanders or first responders, resuscitation education, indirect evidence from clinical trauma care and from full-scale simulation suggests that cognitive aids, flowcharts, mnemonics, checklists should be used during resuscitation training for healthcare providers. And debriefing, data-driven, performance-focused debriefing is the background of our simulation education. It should be used by rescuers and needs to be integrated into the ALS education for healthcare providers, and debriefing as a teaching goal must be applied in real-life situation for in real resuscitations of cardiac arrest victims, not only for educational level. So kids save lives. That's the ESC, very well-known program, which is aimed on educate CPR to as much as possible children worldwide, teaching by teachers and medical students, teaching in schools, And this is also the question of tailoring education to a specific group of people. And we use CPR competencies depending on the age of children, from kindergarten to university. But in general, it's all BLS according to the ESC guidelines. School teachers are the most competent person to train children, and they shall learn for this resuscitation school programs, and definitely they should learn the key elements, the specifics, and the way of teaching might be chosen by these teachers depending on their local requirements and circumstances. And we have no evidence on which educational strategy is the best, which strategy is the best to teach the school children, which is the most effective. We have the room for improvement in this field. And in resuscitation teaching, educated students, medical students, may act as teachers also, and may take part in Kids Save Lives program and educate school children. So, finalizing my presentation, key points. Key points in resuscitation education for bystanders and first responders. So our simulation education should be tailored to this group of people, bystanders and first responders with duty to respond, taking into account that the key elements are to enhance willingness to perform CPR. The cornerstone is to train the chain of survival, to train everything using various feedback devices, at least the metronome. This education should be spaced, so distributed over time, and frequent retrainings are required. Slightly different situation is in the field of healthcare providers. Their educational needs should be tailored also. All of them should be taught high-quality CPR from BLS to ALS level. Children and adults, maybe special circumstances depending on the workplace. The accredited advanced life support course is the golden standard for healthcare providers. CPR training, including team and leadership training. We have evidence that cognitive aids should be used in healthcare providers, simulation education, resuscitation education, and also debriefing is the cornerstone of that. Thank you very much for your attention. I'm ready to answer to your questions. Thank you.